I have to talk about the results of a job that we do with a lot of people that are here in this room. There is a consensus conference on cranioplasty. First of all, why a consensus conference on cranioplasty? And I took slides from Randy commenting the BTF guideline for the edition in the last ICRAN in Naples. And of course, when we have not enough evidence, so we need a consensus conference because it is a tools where we can put in all experts that discuss about where they agree, why they don't, when they don't, and after they can produce some suggestions, some recommendation for the daily practice neurosurgical activity. And so we organized a consensus conference at the last ICRAN in Naples. It's about 50 participants from Nigeria, USA, Brazil, Italy, Hungary, Poland, Pakistan, Finland, Colombia, India. And that's the power of ICRAN to meet all the people inside to decide something of useful for our daily practice. The areas for ongoing are under uncertainty about cranioplastic, are indication, technique, material, timing, hydrocephalus, pediatric, and all of these topics will be discussed in this conference. About indication, we well know the restorative effect of cranioplastic. Before cranioplasty, this is an elegant study 20 years ago conducted by Marek Czosniak in Cambridge, where before cranioplastic, after infusion test, we know that there is no brain compliance. And after cranioplastic, the brain compliance is restored. So close the box. So we have a restoring of the CSF cycle. And we have also restored cerebral blood flow, but we know that this not correlate directly with a good clinical outcome. So we know that it works, but the outcome is not in the same correlation. And about Brain Trauma Foundation guidelines, the only sure suggestions is to perform a decompressive craniectomy no less than 12 or 15 centimeters. And so we decide in a consensus conference to talk about cranial reconstruction with these sides of bone flap. About material, there is a lot of uncertainty. Few data are about the autologous bone, because we know that it is the only material that presents a complication related to its own constitution. That means the bone, there is a bone flap resorption. No alloplastic, of course, has a resorption. As reported in this last review, the bone flap resorption can reach 20% of cases. But still now, we have no idea about the ideal material among the available material like polymers, metals, and ceramics. About timing, there is a lot of uncertainty. First of all, we all know that we can have different scenarios after decompressive craniectomy. And so we have different scenarios, a different clinical consideration before to perform a cranioplastic for different patients. The last collecting data show that the impact of timing about outcome cranioplastic is not so clear. Maybe there is no difference, or there is some trend in literature data to propose an early cranioplastic, but still now early is not well defined. 3 months, 2 months, 3 weeks. What is sure, what is clear, that we should abandon the concept of a chronological number as a cutoff of ideal cranioplastic. We should consider as a cutoff the patient, not the timing. And so it is possible also to perform a cranioplastic after 15 days after bone removal. So it's interesting that also when you perform an early craniosurgery or ultra early craniosurgery, we can note after on average of 90 days that we can observe an increasing of complication. And also when you perform a ultra early neurosurgery, we have a group of patients that doesn't develop a complication in the first 3 months. About hydrocephalus, another very controversial topic. About diagnosis, we well know the clinical signs and symptoms of hydrocephalus, but when the patient is too injured to display symptoms, we can consider the same statements of Dandy 100 years ago, that it is very difficult to prove. And the proof that it is very difficult to prove that we have a lot of radiological criteria. So that means that we have not one right radiological criteria, and we try to understand which is the best radiological criteria. Even we are still trying to understand which is the best CSF dynamics test to prove post-traumatic hydrocephalus. And about the timing of treatment of hydrocephalus, when implant the shunt before cranioplastic or during cranioplastic or soon after cranioplastic. It seems that before cranioplastic maybe could have more problem. And even about a lumboperitoneal shunt placement is not sure is better or not than ventriculoperitoneal shunts. And about the timing, after concomitant, before, in literature there is no clear data, even for external ventricular drainage. And about pediatric cranioplastic, this is a last systematic review and a few data about the certainty of this topic. So the first step one of consensus conference cranioplastic between October 2017 and February 2018, I sent 1,500 emails to all the authors of papers about cranioplastic. Step two, we collected in a shared directory about 300 papers over the last 5 years about cranioplasty to share on the participants to analyze the literature. And in step three, we decide the 5 more uncertain topic. Step 4, we perform consensus meeting at ICRAN 2018. So we discuss in 5 separate meeting rooms the topics. And after consensus conference in Naples, we start to prepare the draft, and the 2 facilitators of each room prepare a draft for that room. And after we shared the draft. The draft was prepared on the voting statements that we voted in consensus cranioplasty. So overall, 50 consensus statements were voted, and the highest rate consensus was about indication and technique. The mean agreement was 92.8% for adults and 91.4% for pediatric, and also an higher rate of consensus about material. The lower rate, of course, timing and hydrocephalus, but the lowest rate was about materials and timing for pediatric. So that's all the statement. And of course, it's not clear, but just to show you how timing, the panelists and the assembly needs a lot of statements to define consensus about timing. But there is more lot statement about hydrocephalus. We voted for diagnosis, this group of statements, and for surgery, this group of statements. Less statements, of course, for indication techniques and materials. So still timing and hydrocephalus remain at high level of uncertainty, high level of controversy. And about pediatric cranioplastic, it was they didn't define statement about hydrocephalus. They didn't reach any agreement about hydrocephalus, so they define indication, technique, materials, and timing. They say this hydrocephalus is so rare in pediatric patients, and so is more an anecdotal experience than, so they decide to not produce recommendation. About indication techniques, 100% of agreement was reached about the fact that we should perform cranioplastic in absence of medical contraindication. And the indication, it's clear, is not just a restorative cosmetic effect, but the indication are also in a restorative physiological effect. About materials, the only 100% agreement was about that bone graft show resorption and a risk of resorption. Still, the timing has just one statement with 100% of agreement, and that the clinical condition of the patient should be taken into consideration when deciding the timing of cranioplasty. So still, again, this is a real concept that we have to suggest in performing a cranioplastic. And about the hydrocephalus, the 100% of statement, the agreement of statement is that we need further research. I mean, this is the only 100% agreement. It's clear that we have no clear idea about hydrocephalus. About pediatric cranioplastic, 100% of agreement in assumption is that the compressive craniectomies for children, especially young children, were proportional to size of child. So they abandon the concept of the cutoff of sides, and they discuss about all the cranial reconstruction. And the cranial reconstruction that would be proportional to the size of the defect. No 100% of agreement in pediatric for materials, neither for timing. So, the consensus reached some suggestion that we need further research for hydrocephalus and for especially for timing. But also it's clear that cost efficiency is a real issue, and cheaper solution may not necessarily stand up to long-term scrutiny. For example, the bone flap resorption could be correlated with a high rate of complication, and so to increase the cost of treatment, of management. So, of course, bone is the cheaper solution, the bone flap, but the future research should be focused to try to have some more alternative, more cheaper alternative, because the bone flap is not so cheap if we take in consideration the complication. And of course, we need also more clear tools about diagnosis, about clinical diagnosis, about the clinical scale for the follow-up. So the consensus conference carried out the that we have no absolute data about cranioplastic. There is a lack of evidence, and we want pinpoint what we have to do in the future. Thank you.